Good morning. It's my pleasure to introduce Dr. Ralph Lewis, who is going to talk to us about whether we are pathologizing the normal human condition, but more importantly for this group, the implication for psychiatric training. How do we train or medical student, resident, graduate student, and fellow. I need to open my document. I'm sorry. It's always too many windows. So some of you know Dr. Ralph Lewis. He's a staff psychiatrist at Sunnybrook Health Sciences Centre, an assistant professor in the Department of Psychiatry at the University of Toronto. He obtained his MD in South Africa, where he grew up. He completed his residency in Toronto, and then he did a 2-year clinical research fellowship at Sunnybrook and in the PET Center at what was at that time the Clark Institute of Psychiatry, now the Center of Addiction and Mental Health. He obtained at that time a Master of Science in Neuroscience at U of T, and he has been a staff psychiatrist and a member of the department since 1998. The reason he's been asked to give us his presentation is because he has developed during the past few years a track of in science education as a science educator writer. He wrote a book called Finding Purpose in a Godless World, Why We Care Even if the universe does not. And I have read that book and I recommend it highly. Very interesting perspective on life and almost an existential issue. He's also a blogger for Psychology Today, and his online article have attracted 1.4 million views, and 30 of his 53 articles have been promoted by the publisher as essential reading. He has also interacted on social media with some of the thought leader of our modern world, including Steven Pinker and Max Rosner and Brian Greene. And I could say more. He has been also on the local TVO in the agenda, and he has been also a guest on NPR. So without any further ado, I'm going to pass the virtual mic to Dr. Lewis, who I think will share his screen also and present some slide. If you cannot read the slide, they will also be shared with you after the presentation.
Thank you very much, Dr. Moussan, for that kind introduction, and thank you and the Executive Committee for inviting me to speak to the SAC. I'm truly humbled by this invitation. I'm going to share my screen now. Let me know if you can't see the slides. Okay, this should be up now. The topic of my talk is, are mental disorders increasing, especially in youth, or is the human condition becoming medicalized? Implications for psychiatry training. In this presentation, I will first summarize the available data. This will be slightly more than half of my presentation. It will be the drier part of the talk, but it's important in order for us to know more objectively if what we're seeing in the clinic is a real and widespread phenomenon and its magnitude. Then I will offer my own interpretations of the data and suggestions regarding psychiatry training, including a speculative way of conceptualizing many disorders that I use to help medical students and residents to think more flexibly. Let's begin by framing the issue. There is a perception among the general public, frequently articulated in the media, that the prevalence of mental disorders has been increasing significantly, especially among young people. Self-reported mental health problems have increased, especially among young people. For example, in 2015, 34% of Ontario high school students indicated a moderate to serious level of psychological distress with regard to symptoms of anxiety and depression. 14% indicated a serious level of psychological distress. And in a national survey in 2017, 63% of 18 to 29-year-old Canadians surveyed considered themselves someone who struggles with anxiety. Among females in this age group, the percentage was even higher at 71%. Rates are similarly high in other Western countries. For example, in a 2018 Pew poll of American 13 to 17-year-olds, 70% thought anxiety and depression were a major issue among their peers. This apparent mental health epidemic predated COVID-19 by a number of years and has been further amplified by it. Here's an example of a prominent media article about the apparent epidemic, this one from the New York Times magazine in 2017. Some studies suggest the increase is mainly in self-reported symptoms or perceived need for help. A study of global prevalence of anxiety and depression from 1990 to 2010 suggested that the perceived epidemic of common mental disorders is most likely explained in part by higher rates of psychological distress as measured using symptom checklists, greater public awareness, and the use of terms such as anxiety and depression in a context where they do not represent clinical disorders. In a population-based retrospective electronic cohort of 6 to 18-year-olds between 2003 and 2011, the incidence of anxiety symptoms more than tripled over the study period, whilst that of diagnosis remained stable. There appeared to be a preference over time for the recording of general symptoms over diagnosis for anxiety in children and young people. A 2015 review of the largest epidemiological surveys available suggested there was no evidence that the prevalence rates of anxiety disorders had changed in the past years, and that it was more likely that this heterogeneity was due to differences in methodology than to cultural influences. From the 1983 and 2014 Ontario Child Health Studies, the overall prevalence of perceived need for professional help increased from 6.8% to 18.9% among 4 to 16-year-olds. There was an increase in overall prevalence of disorders among 4 to 11-year-olds, but this was attributable to increases primarily in hyperactivity among boys. Although the overall prevalence of disorders did not change among 12 to 16-year-olds, conduct disorder decreased, while emotional disorder, depression and anxiety, increased. Notice that finding that conduct disorder has decreased. In a number of high-income countries, there is evidence that conduct disorder peaked in the early 1990s and then decreased. This generation, known as Gen Z or Gen Z, has lower rates of violence too. A Swedish study using data from the Stockholm Public Health Surveys found that the mean level of distress among 18 to 24-year-olds who utilized psychiatric services decreased between 2002 and 2010. In other words, a decreased threshold for seeking help, while it remained fairly stable in older age groups. Another Swedish study using data from the Swedish Annual Level of Living Survey found that between 1981 and 2004-2005, there was an increasing prevalence of self-reported anxiety in all groups except the oldest. And the highest increase was found in 16 to 23-year-olds, with more than a 3-fold increase in females and a 2.5-fold increase in males. Here are benchmark data on rates of anxiety disorders and other mental disorders in children and adolescents from the US. The National Comorbidity Survey replication applied DSM-4 criteria in face-to-face interviews with over 10,000 US teens aged 13 to 18 in 2001 to 2004, and found that 31.9% met criteria for an anxiety disorder by the age of 18. That's lifetime prevalence. But this included 19.3% with a specific phobia. Only 8.3% of adolescents had suffered severe impairment of functioning from an anxiety disorder. An estimated 49.5% of adolescents had any mental disorder. 22.2% had severe impairment. Again, that's lifetime prevalence up to that age. The 2016 National Survey of Children's Health and nationally representative parent proxy survey of US children younger than 18 in 2016 found that 16.5% of US youth aged 6 to 17 currently experienced a mental health disorder, which included depression, anxiety, and ADHD. Some studies do report an overall increase in diagnoses. Drawing from 10 years of data from a large annual web-based survey, the Healthy Mind Study, of US undergraduate and graduate students, the rate of past year mental health treatment increased from 19% in 2007 to 34% by 2017, while the percentage of students with a lifetime diagnosis of a mental health condition increased from 22% to 36%. The prevalence of depression and suicidality also increased, while stigma decreased. Drawing from the Healthy Mind study and another large sample of US students that included both community colleges and four-year institutions in 2016 to 2019, the same author found that more than half met criteria for one or more mental health problems, roughly 1/3 screening positive for depressive and anxiety disorders, and approximately 15% reporting suicidal ideation. I'll just briefly summarize these next two slides. In this slide, two studies draw on data from the National Survey on Drug Use and Health in the US to show increased rates of MDE diagnoses in youth in the last 2 decades, more than for adults. And the effects were primarily a cohort effect, possibly due to cultural trends in younger cohorts, the authors speculated. And in this slide, two studies show increased outpatient visits for US youth in the late 1990s and early 2000s, increasing at a much faster rate than for adults, nearly doubling in fact, mainly driven by an increase in less severely impaired youth. At the bottom of the slide are NIMH statistics showing a 42% increase in ADHD diagnoses in US children from 2003 to 2011. Let's look at the complicated trends in suicide rates from the CDC data. Youth suicide rates have been rising since the 2000s, beginning around 2007 in the US and possibly elsewhere, after having previously fallen since the early 1990s from still higher levels. The uptick in the US in 2007 to 2015 has been especially among girls. The youth suicide rate had previously declined to its lowest point in 2007 before starting to rise again. It remained lower for boys in 2015, relatively, compared with its peak in the mid-1990s, as the decline since the mid-1990s had been steeper for boys than for girls. More recent data suggests that rates are continuing to rise, but it is not uniform by sex. Rates in young males may actually be declining, but are outpaced by large increases in young women. In Ontario, a CAMH study found no change in suicidal ideation and attempts in high school students from 2001 to 2015. In national Canadian data, suicide rates were trending slightly upwards in females aged 10 to 29 in 2000 to 2018, while they were trending downwards in males in this age group. Non-suicidal self-harm has increased greatly in the last couple of decades, especially among girls, mostly as a coping strategy to achieve relief from thoughts or feelings. For example, the prevalence of self-reported lifetime non-suicidal self-harm increased in England across all age groups from 2.4% in 2000 to 6.4% in 2014. In 16 to 24-year-old females, it increased from 6.5% to 19.7%. In Ontario, rates of youths with self-harm ED visits actually fell 32% from 2.6 per thousand in 2003 to 1.8 per thousand in 2009, but then rose 135% to 4.2 per thousand by 2017. Females were more likely to have self-harm ED visits. Self-cutting used to be considered a fairly reliable sign of personality disorder, whereas today it is simply a common coping strategy among emotionally upset girls. It seems likely that social contagion is a significant contributing factor in this dramatic increase. What about ER visits and hospitalizations? From the Canadian Institute for Health Information, in children and youth aged 5 to 24 between 2008-2009 and 2018-2019, there was a 61% increase in ED visits, a 60% increase in hospitalizations for mental disorders, and a 26% decrease in hospitalizations for other conditions. In the interest of time, I'll skip over these next two slides, but I just wanted to put them here to show that, unsurprisingly, the pandemic had an overall worsening impact on youth mental health. Benoit was actually an author on the first listed paper, which was basically making predictions early in the pandemic about the coming mental health problems. Let's summarize the data. Self-reported mental health problems have increased in recent decades, especially in young people. Thresholds for seeking psychiatric help appear to have dropped, especially in young people. Diagnoses by psychiatrists and primary physicians of anxiety disorders, depression, and other mental disorders such as ADHD have increased in recent decades, especially in young people. These increased diagnoses appear to have been mainly in the mild to moderate range of disorders. Rates of serious mental disorders appear to be stable, mostly, but the data are mixed. The prevalence data overall are complex and difficult to interpret, plagued by the question of whether increased rates represent a real increase or just an increase in self-reported symptoms and help seeking, and possibly increased willingness of psychiatrists to make a diagnosis. Unsurprisingly, rates of self-reported anxiety and depression increased further during the pandemic, especially in young people. What might account for these increases in self-reported symptoms and also in perceived need for professional help, and maybe increased rates of diagnoses by psychiatrists? Pre-pandemic, the actual rates of mental disorders may indeed have risen to some degree. Life may arguably have been more stressful for youth than ever before. Defining mental disorders is slippery, having fuzzy boundaries with normality and heavily reliant on subjective symptoms. DSM-5 applies categorical definitions to what are mostly dimensional phenomena because it's harder to operationalize dimensional definitions. Mental health education and destigmatization campaigns and patient advocacy groups have probably all inadvertently driven up rates of patients presenting with subthreshold symptoms. Many other factors may contribute to self-labeling. The internet, celebrity influence, peer influence or identification with other patients, social contagion, and suggestibility. In an extreme example, during the pandemic, quite large numbers of teenage girls have been presenting to Tourette's clinics around the world with Tourette's-like tics after exposure to influencers on TikTok videos. Another factor that is hard to ignore is that victimhood garners a lot of sympathy. There is also, of course, the strong influence of pharmaceutical marketing, both to physicians and to the public. And there are the incentives of academic accommodations and in older adults, disability benefits, and of course, physician reimbursement, especially in the US. Why especially youth? Young people are especially prone to all these influences. Everyday language has changed. Today's youth seem almost to have replaced the use of words like stress and distress with terms like mental health issue or mental disorder. The apparently increased rates of anxiety and depression in youth have been blamed on smartphones and social media as the main cause. Jean Twenge, an American psychologist researching generational differences, wrote an influential book and article in The Atlantic in 2017 making this claim, but more careful studies haven't borne this out. A diagnosis offers an explanation for a person's difficulties. It helps them feel understood. It simplifies complexity, helping make sense of things and providing a sense of order to the inexplicable and chaotic. It provides validation and legitimacy to one's struggles. It brings sympathy and perhaps justification for one's shortcomings or behavioral difficulties. It also confers a sense of identity and group belonging. All these factors are even more important for youth. We seem to have gone from destigmatization to frank desirability of diagnosis. Surprisingly, there's even been a very noticeable trend lately of people self-diagnosing with BPD, a previously undesirable diagnosis. Quotes from patients of mine are revealing. I would like a diagnosis so I know that something is going on and I'm not faking it, so I have a valid reason to feel awful sometimes and not have people get on my case about it. Another patient told me, in my age group, you need an official diagnosis to explain why you have the difficulties you do. So what are the implications for psychiatry training? We need to instill an appreciation for the unique vulnerabilities of young people, and especially girls and young women, both in terms of their actual stress and their perceived stress, and the role of generational and sociocultural factors in affecting those perceptions. We need to instill awareness of the consequences and risks of overdiagnosis and the excessive appropriation of clinical language by the general public. Real mental illness becomes trivialized and psychiatry becomes delegitimized. If everyone has a mental disorder, then no one does, and the concept of mental disorder becomes meaningless. It becomes harder for the people most in need of psychiatric services to access the already overloaded system. We need to teach students and trainees the uncertainties, complexities, and nuances pertaining to the definition of a mental disorder. We need to contrast the dimensional versus categorical approaches to diagnosis and the limitations of the DSM approach. I tell my students and residents that the DSM is the worst bloody diagnostic system available, except for all the rest. This is the rather convoluted DSM-5 general definition of a mental disorder, which many psychiatrists may not actually have read, but I'll skip over it for now in the interests of time. Here's an example of a graph I use when teaching medical students and psychiatry residents as a way of illustrating other possible ways of conceptualizing many mental disorders. We need to teach students that mental disorder is not a yes or no question, but rather a question of degree. Common traits can be visualized on the x-axis of the bell curve of the graph I showed. An obvious one is anxiety. Notice that both too much and too little of a given trait may be maladaptive and may correlate with disorder. For example, too little anxiety, especially if far to the left end of the curve, may correlate with antisocial personality traits. More speculatively, if we consider executive function or cognitive control on the x-axis, those constructs are almost synonymous, by the way. Can you have too much of that good thing? Cognitive control includes cognitive flexibility, so presumably the more the better. It also includes attentional control. Reduced attentional control can actually be beneficial in a range of cognitive tasks and can aid creativity. Being too focused might correlate with perfectionism, fixation on detail, and excessive control, predisposing, for example, to OCPD or anorexia nervosa. This is a speculative model and obviously has limitations and needs data, but it's a way of getting students and trainees to think outside of the DSM box. It maps onto other established models, particularly the 5-factor model of personality, which conceptualizes the big 5 personality traits on bell curves, with both ends of the curve being maladaptive. Anxiety maps onto neuroticism. Too little neuroticism is maladaptive. Cognitive control maps onto conscientiousness. Too much conscientiousness is maladaptive. It is also compatible with RDoC, for example, negative valence systems and the subsystem of potential threat for anxiety, and cognitive systems and the subsystems of attention and cognitive control. This conceptualization of mental disorders reflects a further move away from the old axis 1, axis 2 dichotomy of DSM-4. Finally, let's consider ADHD as an example. Sorry, my slides just disappeared, but I have it here again. Let's consider ADHD as an example and ways of thinking about it outside the DSM-5 box. The question of increasing rates of diagnosis may be even more complicated than we've considered. ADHD may be identical to the left end of the executive function bell curve. Modern societies have dramatically skewed the environment relative to the Paleolithic environment in which our species evolved for most of its history. The modern environment is highly structured, constrained, complex, time-pressured, requiring tremendous attention to detail, demanding much higher levels of self-control, patience, persistence, and the ability to work tediously toward very distant abstract goals. People may be significantly disadvantaged by being at the left side of what can be considered a normal continuum for executive functioning or cognitive control. For practical purposes, these people can be regarded as having a disorder, even though it's not a true neuropsychiatric disorder in the pathological sense. A large swath of the population may be disadvantaged in this way, and their numbers can be expected to increase as the modern environment becomes increasingly skewed toward favoring high cognitive control. There is a caveat. There may additionally be some true disorders that can present with marked ADHD features, for example, fetal alcohol syndrome, but these are a small minority of all people meeting criteria for ADHD. Most individuals meeting ADHD criteria do so simply as a function of population diversity. Much of the normal population diversity is heritable. In fact, individual differences in executive functions have been found to be almost entirely genetic in origin. Seen this way, ADHD is not just one among many DSM-5 categorical diagnoses, but rather a fundamental and common set of human traits, that of having relatively weak cognitive control with all the ramifications of less self-regulation. ADHD may therefore actually be one of the most important underlying contributing factors to a wide range of mental disorders. Thank you very much for your attention, and I look forward to hearing the collective wisdom of the very considerable expertise in the room.